Yeah.
So I wanted to let everyone know that this presentation is being recorded, and to ensure a quality program, we are going to keep you muted. So if you have any questions, please go ahead and put them in the chat or into the Q&A, and Rachel will ask them at the end. Over to you.
All right. So nice to see you all. I know some of you I've met before and some of you I haven't. I'm with Diabetes Education at North Kansas City Hospital. I do inpatient and outpatient diabetes education and community events such as this. So today we're primarily talking about diabetes medications and treatments. And then we'll also kind of touch on diet as we go through those medications, because it really does matter what medications you are on as to what kind of diet you need to follow. All right, so prescription treatment of diabetes. We actually have two groups here, and the first is diabetes medications. These are medications that directly treat blood sugar. Okay, sometimes they're known as anti-hyperglycemics, so anti-high blood sugar, or anti-diabetics. And they could be pills or tablets or injections. Right. Supportive medications is another group of medications that's often associated with diabetes. And these are medications that treat chronic health conditions or that are preventative, medications that are preventative for health conditions that are commonly associated with diabetes. So health conditions such as high blood pressure or high cholesterol are not only associated with diabetes, but they can affect diabetes. So from both sides of things. First, we're going to talk about diabetes medications. So we're going to divide that into oral medications, also known as pills or tablets, and injectable medications. Now we say injectable because not all medications that you use a needle for, that you inject, are insulin. There are other medications that you actually inject outside of insulin. And so we're going to divide them into those categories. All right. So this is a very detailed timeline. What I want to draw your attention to is when different medications came out. So a lot of people are worried about different medications, especially you'll see Metformin, which you'll see here was developed in 1959. And it was, so it says available outside the US in 59. It was available inside the US in 1961. Sulfonylureas, which you'll see in the top middle, developed in 1956. These medications have been around for a really long time. And the nice thing about that is that we can see how safe they are. We can see long-term effects of all of these medications. If you go back a little bit, you'll see when insulin was first administered to a human, which was 1922, so not that long ago in the grand scheme of things. You know, diabetes has actually been mentioned in hieroglyphs from Egyptian times. And so it's actually taken us that long to develop a human insulin. In 1946 was when NPH insulin was developed, and that extended insulin from a 4-hour window to a 12-hour window, so we could help stabilize blood sugars over time. This type of insulin is actually still available, and it's pre-patent, and so it's in some places, in some states, it's available over the counter. You'll see a lot of the other medications that we'll talk about, the GLP-1s, SGLT2s. I know they sound like very complicated chemistry names, but we'll kind of talk about what they are and how they work. Okay. So I just like to show the timeline to let you know that, you know, you see all these commercials on TV and they say, oh, this medication's horrible. It's been around since 1961. In general, it is safe. Yes, every medication other than insulin carries with it some precautions, but they are very safe and have been studied very well. Okay, so we'll start out with what is the first line medication for diabetes. When you go to your doctor and they tell you you have diabetes, most likely they will recommend metformin, because metformin, like I said, has been around since the 60s. And it is very good at what it does. It actually works by lowering the sugar that's produced by the liver. And then it also works by helping your body use its own insulin. So everybody produces insulin from their pancreas. But when you have type 2 diabetes, your body can't use that insulin very well. It's resistant to it. So it wants more and more insulin. Well, metformin actually works on those cells to help the cells use that use the insulin really well. And so that can work to lower your blood sugars and therefore lower your A1C for, years and years. Many people stay on this medication for a very long time, and it's completely safe to do so. Now, the downside of this is that it can cause a little bit of nausea and a little bit of diarrhea or stomach upset when you are first put on it. Your body has to adjust to it. So unfortunately, a lot of people aren't informed about this. And so when they start having these reactions, they do think it's an allergic reaction, when really the body has to get used to this new thing. And so that can cause those symptoms, and they usually go away within 1 to 2 weeks. Okay. The other thing I want to mention about metformin, some really fun facts about it. This year, they actually published several studies that showed that metformin is actually protective against Alzheimer's. So if you're at a high risk for Alzheimer's, taking this medication has a bonus effect to reduce that risk. It also reduces risk of cardiovascular disease in 2 ways. One, it helps with weight loss. You can lose up to 2% of your weight within the first 6 months of taking it. The other thing is it helps to reduce cholesterol absorbed in the body. So 2 very nice aspects of metformin. One precaution that I tell all of my patients about is when you take metformin, you really need to take a B12 vitamin. If you take a multivitamin, that includes B12 typically, but metformin, or the other 2 names, Fortimet, glucophage, they can actually decrease the absorption of B12. So it's not that you're not getting it from your food, but you're just not getting as much. Over time, that can cause, it's an interesting thing. It causes tingling in your feet, which can sometimes be mistaken for diabetic neuropathy. It can also cause depression-like symptoms. So not that you have depression, but that you start being overwhelmed by more simple things in your life that wouldn't normally overwhelm you. So I always recommend, if you're taking metformin, please take a B12 vitamin. Very simple, over the counter. You can get it pretty cheap at CVS, Walmart, or Hy-Vee. All right. So that's our first line medication. Again, safe. I mean, they've studied this on patients out to 40 or so years. It actually helps maintain. So when you start metformin, you also want to start diet changes and exercise, right? But metformin, even when you get your A1C in range, can actually help you maintain those levels. So very good medication. It's also occasionally used in a disorder called PCOS, which is it's a autoimmune disorder that happens. It's polycystic ovarian syndrome. So it happens in your ovaries, and it can actually help with women who are trying to get pregnant. Okay, so that's metformin. Again, first line, but we have others. So a lot of patients think, oh, metformin didn't work for me. I'm not trying any of these other meds. Well, not all medications work for everyone. Okay, so the next line medication is called a sulfonylurea. This is glipizide, glyburide, or glimepiride. They do have other names, especially brand names like Amaryl. What is the other one? There's another one that's pretty common. Sorry. But these medications actually make your pancreas give you more insulin. So you're already making insulin, but now it's kind of poking that pancreas like, hey, give us some more insulin. The downside is when you produce more insulin, you store more sugar. And so when you store more sugar, there is a risk of weight gain. Okay. There's also a risk of low blood sugar. Now, this typically happens when you're skipping meals. You know, if you're the type of person that only eats 2 meals a day, but you take this sulfonylurea or glipizide, glimepiride, there's the chance that at that meal time in the middle, you may start to have low blood sugar. So that's something to keep in mind when on this medication. It is often prescribed with metformin. So metformin helps your body use insulin, and the sulfonylurea helps your body produce more. So you're working at it from two different directions to get that blood sugar under control. All right. So DPP4 inhibitors. This sounds like a very complicated name. DPP4 is a hormone that makes your body, okay, it's a complicated process and it takes me even a minute to think through it. Okay, so it actually increases what's called a GLP-1, glucagon-like peptide 1. Okay, so when that is increased, insulin secretion is increased, and that decreases the amount of sugar secreted from the liver. Okay, so this DPP4 inhibitor makes the body secrete more GLP-1, but that's the chemistry side of things. Okay, ultimately, it works very similarly to the sulfonylurea. Okay, it increases insulin secretion. But then part of it also works like metformin, and it decreases the sugar that's secreted from the liver. All right, so it's kind of similar to a combination of the two, but it works on a different hormone in the body. Okay, it can cause stuffy or runny nose. It can cause sore throat, headache, or kind of upper respiratory infections, just that kind of cough. All right. There is a slight chance of low blood sugar with this medication as well, but it's much less than with the sulfonylureas. Okay. Next, medications. And I know that there are a lot of medications out there. I just want you to know that, you know, when you're going to your doctor and you're talking to your doctor about ways to treat your diabetes, there's more than one way to skin a cat. All right. There's more than one way to fix your diabetes. And I want you to have all that information. So when your doctor says, hey, let's try this, you at least have some knowledge of that and don't feel so blindsided. You know, you manage your diabetes most of the time. And so you should be informed when you go to talk to your doctor about these things. Okay. So let's get on to the next medication. We only have 4 more that are pills. So everything we've talked about so far comes in a pill that you swallow. These are not injections. All right, SGLT2 inhibitors. These are Invokana, Farxiga, or Jardiance. They increase urinary glucose excretion. So what that means is you're peeing off any excess sugar that's in your body. Okay, so you eat a bunch of sugar, now you're just going to pee it off. All right. The downside of this is it can cause increased urination or urgency. Rarely causes low blood pressure. I mean, that's pretty unusual. But it does have a high chance of urinary tract infections or yeast infections. And the reason is you have to think about bacteria and yeast and how they grow. When you make beer, you actually mix yeast and sugar, and that allows the yeast to grow and make this drink. Okay, so if you're excreting sugar in an area that already carries yeast or bacteria, which all of us do, right, then that sugar gives those yeast and bacteria an opportunity to grow. So the biggest thing with SGLT2 medications, and we'll talk about others too, but the biggest thing with this medication is you have to follow a recommended diet that you talk to your doctor about. Because if you are taking this medication and think, I can just eat whatever I want as long as I take this pill, you're going to run into problems. But if you're taking this medication and watching how many carbohydrates you're eating, not eliminating, but decreasing, then you can actually reduce the risk of those infections. So this, and actually every medication on this page, it's very key that you watch your diet when you take them. The next medication is a GLP-1. And remember on the last page, let's go back for a second. You see on the DPP-4 inhibitors, you see the glucagon-like peptide 1. So this increases that. We're going to go over here to the GLP-1 agonist. So that actually fights against GLP-1. And it does a very similar thing, but in a slightly different way. So it increases how much insulin you're getting. It decreases the amount of sugar from your liver. And then it decreases the amount of sugar. So it decreases the amount of sugar that your liver gives, and it actually decreases the amount of sugar your liver makes. So you don't store that extra sugar as fat, right? So that actually means that this medication is great for weight loss. It's actually approved for weight loss, cardiovascular disease, and diabetes. So it's an overall really good medication. It also delays stomach emptying. So, you know, when sometimes you eat something and then you feel like your stomach's empty suddenly. Well, if you eat something and it stays around longer, so your stomach doesn't get rid of it as quickly, you're going to feel full longer. You're not going to be hungry. And that aids in weight loss and therefore blood sugar control as well. Now, the downside is this medication can cause nausea, headache, and it does have that risk of low blood sugar. So it's very important that you eat for this medication. You know, so you're eating things that are healthy for you, that are whole grains and can sustain that blood sugar at an even level, and that will reduce that low blood sugar, which is those whole grains, sorry. And fibers. Fibers are really great with this medication. Again, this must be used with diet changes to reduce complications because it does have a slight increased risk of yeast or urinary tract infections. Okay. This medication, is rather new. And I say that, and if we went back, we would see that it's actually been around for about 20 years. But until recently, it was only around in injection form. And this is actually a pill form of it that you take daily. And so far, we've seen that the results are the same as the injection. The downside is that it does cost a little bit more because it's a newer medication. So kind of keep that in mind. The next medication is called TZDs. It's thiosides. I can't even say it properly. Okay, this is Actos or Avandia. Some people are still on these medications, however, they're not used very often anymore. And the reason is they do have a risk to cause or worsen heart failure. They have a risk of swelling, fluid retention, weight gain, and some macular edema. Now, while this risk is low, when you have diabetes, your risk of heart disease is actually higher than that of other individuals. So increasing that risk at all is sometimes not something that doctors are willing to risk. Okay. Again, these risks are very low, and if you're taking it, generally your doctor is monitoring all of the things that it could cause a problem with. Or your doctor thinks that it's safe in your case because you don't have a high risk for these other disorders. But that's why it's not used as often. If you do have fatty liver, which can come from obesity or being overweight, or from alcoholism, then you aren't able to use this medication because it does process through the liver. All right, last one, guys. Glad you hung in there for me. Meglitinides, again, another medication that's not commonly used. It stimulates insulin from the pancreas. It is still a very good medication. Its side effect is hypoglycemia, or it could be hypoglycemia or low blood pressure. But a lot of the other meds not only do that, but they also reduce the amount of sugar released from the liver. So this only addresses one component, and that's why it's just not very commonly used. Okay. But it's a pretty safe medication overall. And so it, on occasion is used as just an extra boost. Maybe you're taking metformin and your doctor thinks, you know what, let's just give you a little bit extra to get you over that hump of blood sugars. All right, now we're going to jump into injection medications. So you will see that there's only one here. And there is actually another injection medication that's used for diabetes, but its goal is actually weight loss. So when it was originally approved, it was made for weight loss. It was made for what's called early satiety. So making you feel full earlier in your meal. So you get halfway through your meal and you're like, whoa, I'm way too full. So that can help control diabetes, but that's not its main goal. And so that's why I didn't include it on here. The GLP-1, as we saw before, that Rybelsus. So the second one down, Rybelsus, that's the pill form. The more common form is Bydureon, Victoza, Trulicity, or Ozempic. Okay, so Rybelsus, the pill, is not actually FDA approved to address heart disease at this point because it is a newer version of these medications. The injectable versions actually have been approved by the FDA, so Federal Drug Administration, right, has been approved by that for 3 different, what we call indications. So Ozempic is approved for use for diabetes, it's approved for use for heart disease, and it's approved for use for weight loss, all independently. So now if you're prescribed this for heart disease, it's also going to be preventative for diabetes. If you're prescribed this for diabetes, we know that it's preventative for heart disease, and it actually can lower cholesterol over time. So overall, I mean, I know I'm talking about this one a lot, but overall, this is a great medication. Downside is insurance is a little bit picky about it. They do want you to try metformin and glipizide prior to using this medication because it is a kind of a stronger medication. Hopefully we'll see that change in the future. But if you can control it with metformin, why would you take an injection weekly, right? I mean, pills are definitely preferable to injection. So this medication keeps food in the stomach longer. It increases your insulin when you eat, just like that glimepiride, glipizide, or glyburide, that sulfonylurea. Okay, so it increases insulin production and it lowers the amount of glucose released by the liver, which the sulfonylurea and the DPP-4 inhibitor did. Okay, so it kind of combines a lot of things into one medication, and that's what makes it so useful. Downside is nausea, headache, and hypoglycemia. Typically, the nausea and headache go away, once your body gets used to it. And doctors will actually have you start at a lower dose and then increase that dose to meet your needs. Okay, and that reduces that nausea. And again, I cannot emphasize enough that this medication must be used with diet changes to reduce complications. Okay, the biggest thing with diabetes is it's not one treatment, it's a lot of treatments. And so the diet changes that I'm talking about, if you were here for the last presentation that I did, we talked about those carb countings. So either 45 to 60 grams of carbs each meal, or a quarter of your plate each meal in high carb foods. And that's what's recommended to manage your blood sugars and to keep you full. Sorry, it isn't. Carbohydrates actually provide our body with energy. They are a very good thing. Our brains need carbohydrates for energy, but we need to make sure that we're eating the correct portions of those carbohydrates. So just keep in mind 45 to 60 or a quarter of a plate. If you ever decide to eat fewer carbohydrates than that, I do recommend you speak to your doctor. There are some complications of eating too few carbohydrates. I know the keto diet is very popular right now, and it's really not, it's not really safe for patients with diabetes because you do need those carbohydrates, but you don't use them very well. And so sometimes you can actually develop problems because you're not eating enough. Okay. Let's go on to insulin, and then we're going to pause for questions. Okay. All right. So before we go on to insulin, I thought this was a really fun diagram because it does tell where each medication works in the body. So you have your lovely adipose tissue, also known as fat cells. Okay, so your fat in your body. And the biguanides or metformin or thiazolidinidins, TZDs. Let's go with TZDs. They both help your fat take in glucose, as well as skeletal muscles. So biggest thing that I always encourage patients to do is find some way to get activity. Your muscles can actually use sugar without insulin. Only cells in your body that can do that. Really, really nice. And then the biguanides, the metformin, kind of cashes in on that. And it's like, ooh, we're taking out more sugar. Let's make that extra. And it really helps your body use sugar, especially during times of activity. So you'll see down at the bottom where it says pancreas, you have the sulfonylureas, the glipizide, glyburide, or glimepiride. They make your pancreas secrete more insulin. The meglitinides, same thing. And then there's exogenous insulin. Exogenous insulin is just a fancy way of saying insulin that you give yourself instead of receive from your pancreas. So anytime you're giving yourself a shot of insulin or you receive a shot at the hospital, you're getting what's called exogenous insulin. So something from the outside. All right. Then you have your SGLT2s. They work on the kidneys. The metformin also works on the liver as well as the TZDs. And then you have alpha glucosidase inhibitors. That's kind of a funky class that we didn't even talk about. That can decrease glucose absorption in the intestines. All right, insulin. Here's where things get a little difficult. Nobody wants to give themselves shots. I understand that. But the nice thing is that insulin is all natural. It is something that our bodies already produce. So during pregnancy, it's very common for doctors to prefer insulin over any other pill medication because it is something that's so natural, it's not going to affect the baby. Outside of pregnancy, if you have type 1, insulin is the only thing that's going to treat your diabetes because in that case, your pancreas does not make any insulin. So you have to give what's called exogenous insulin. You have to give yourself shots. When you have type 2, you may require additional insulin. And the most important thing to understand about this is it's very similar to taking a vitamin. If you take a vitamin, say you take iron, right? Say you take an iron pill every day. It doesn't mean that you don't get iron from your meat or from your spinach or your kale or your milk. You still get iron from those things, but your body needs more than you get from those things. So taking that insulin is just like a vitamin supplement. It is supplemental insulin. Okay. So we break this down into two different types. Our body produces something similar to a short or rapid acting insulin. So when you eat food, your pancreas, or when you eat carbs, sorry, very specifically when you eat carbs, your pancreas can actually tell, and it gives you insulin based on how much it senses. So to replace that, we need to give a short acting insulin prior to eating. Okay, so you give it about 15 minutes before eating. Some are longer and some are shorter. What we call regular insulin, you have to give 30 minutes before. There's an inhaled insulin that I didn't, it's very, very uncommon, but there is an inhaled insulin and it works in about a minute. But most insulins you want to give between 5 and 15 minutes before eating. And that insulin is to cover the amount of carbohydrates you're eating. Our general amount of carbohydrates we prescribe insulin for is that 45 to 60 grams, like I mentioned before. So insulin needs to be paired with those carbohydrates. If you were to give insulin and no carbohydrates, your blood sugar would actually go down because insulin reduces blood sugar. If you were to eat carbohydrates and not have any insulin, your blood sugar would go up. So what we're trying to do is balance that teeter-totter. Unfortunately, diabetes is all about balance, which is what makes it so difficult to treat and makes it such a big part of all of our lives, is because it is about that balance. So when you take mealtime insulin, you must eat carbohydrates. Now, there's another way to take this insulin, and that's called corrective insulin. So corrective insulin means my blood sugar is really high, so I'm going to give a little bit extra insulin to bring it down. Okay. Now, this is always something that should be directed by your physician. I don't recommend if you're on insulin that you start kind of tinkering with, oh, my blood sugar is high, I'll give more. Oh, my blood sugar is low, I'll give less. I think that's something you should talk to your doctor about, definitely. Okay. The other type of insulin is what's called long-acting insulin. Sometimes patients take this without the bolus insulin. Sometimes they take both, or sometimes they take one or the other. But more often than not, if you start out on, like when you're starting insulin, you'll probably start with a basal insulin or long-acting. So long or intermediate acting is an insulin that instead of lasts for 4 hours, it actually lasts for 12 to 24. Things like Lantus, Basaglar, Levemir, Tresiba, those are all brands of long-acting insulin. That insulin you give once a day, which is quite nice. It actually helps your body use sugar in between meals. So in between meals, your body still has to function. Therefore, it needs to be able to use sugar as energy. If you don't have insulin or you don't have enough insulin, that sugar just builds up in your system. This frustrates a lot of my patients because they'll say, well, I didn't even eat anything. I haven't eaten anything in 12 hours and my blood sugar is high. Why is that? Well, that's why. It's because your liver actually gives you some sugar to help your body function in between meals. And so your blood sugar can actually spike before you have enough insulin to manage it. So this long-acting insulin is very nice for situations such as that. All right. I'm going to take a look and see if there are any medications about, ooh, how do I do that, Shanna? Okay.
Sorry, I couldn't unmute myself. My mouse wasn't working.
Did you see any questions about those medications that I could answer at this time?
Not yet.
Okay, excellent. Well, if you think of any, we'll go over those at the end as well.
Okay.
I'm going to briefly go over supportive medications. This section isn't very long. You know, there are only 2 areas that we're going to address. There are lots of things that diabetes affects, including thyroid and, you know, weight gain and all sorts of things. But what we're going to talk about is just the 2 main complications of diabetes or corresponding conditions. So hypertension or high blood pressure. When you have diabetes, it actually, when your blood sugars are uncontrolled, it can actually damage your arteries and make them start hardening. Okay? And that over time can cause high blood pressure. So think about your water hose outside. Okay. And the first year you get it, it's really flexible and it works perfectly. But then you forget to bring it in the winter and it hardens, right? It freezes and then it thaws and now it's kind of brittle. And every time you move it, it kind of cracks a little bit, right? So now when you turn on the water, the pressure has nowhere to go because that water hose is so brittle, it's so cracked that it can't expand with that water. So your pressure might be high and then it might be low, and then it might be high and then it might be low. Same thing happens with our arteries. When they have damage or when our cholesterol is too high, that can cause hardening, which causes high blood pressure. So because that's so commonly associated with diabetes, some physicians will actually start you on a medication even if your blood pressure is well controlled. My husband is a very good example of this. His blood pressure is generally perfect, but his doctor wants to protect his kidneys. So he's on a ACE inhibitor like we're about to talk about. When your blood pressure is high, it actually puts a lot of pressure on your kidneys. And over time, that damages those kidneys, and they're very hard to repair, and they take a long time to heal. So it's better to prevent those complications than wait and hope they don't happen. All right. So an ACE inhibitor is also known as a calcium channel blocker. So it's considered safe. It's very well tolerated. There are very few risks associated with it. And it's often given in very small doses. If you have high blood pressure, they may increase that dose. If you don't currently have high blood pressure, they may start you on a really, really tiny dose, like my husband. They're actually able to slow the progression of diabetic neuropathy. So that loss of feeling, tingling, or pain in the fingers and toes. Diabetic nephropathy as well, which is in the kidneys. And then diabetic, what's the name of it? Retinopathy, there we go, in the eyes. It can decrease risk to loss of eyesight. And the bottom of that, glomerular hypertension, just a fancy way of saying you're not putting as much pressure on your kidneys. All right, next medication is for high cholesterol. So when you have diabetes, you're at higher risk of high cholesterol. When you have high cholesterol, you're at higher risk of diabetes. Unfortunately, those two kind of go back and forth. It's a which came first, the chicken or the egg kind of situation. So high blood sugar can increase LDLs and triglycerides. And LDLs are those bad cholesterols. High cholesterol increases risk of heart disease and stroke. So in order to prevent those, many patients with diabetes are put on what's called a statin, and that's going to lower those LDLs. And lower LDLs decreases risk of heart disease and stroke. There's actually a study that's been around, I think, for 70 years now, 60 or 70 years, called the Framingham Heart Study. And it followed all of these patients throughout their lives, and then it actually followed their children's lives. And it looked at their diet and their medications and their risk of heart disease. And the thing that's most consistently found is that high cholesterol really does lead to heart disease. And if you already have high blood sugar, that increases your risk of high cholesterol. So it's important that you reduce that to reduce heart disease. Okay. Statins work by actually blocking. It's kind of like you need two pieces to make cholesterol, and we're blocking one of them. So it decreases your body's ability to make and store cholesterol. So therefore, you end up with lower cholesterol, and therefore it says lower, but it means lower. You lower your risk of stroke and heart disease. The most common of these are atorvastatin, which is Lipitor, pravastatin, simvastatin, and lovastatin. These do have brand names, and I recommend that you look them up if you're not sure what you're on. They do carry a slight risk of side effects, which is muscle aching. Some people can feel pretty tired while on them, but typically your doctor will actually reduce your dose for a time and then increase it later. That lets your body get used to that extra medication. So, all right, that was the quick down and dirty version of diabetes medications. I want to give you this time to ask questions, and let's talk about some medications you're concerned about or you're interested in.
So we are waiting for questions, but that was a lot of information.
It was a lot, and I actually have a handout that I will get to you.
Okay.
So if anybody in the group would like it, we can send that out later. It'll probably be Friday before I get it to you.
Okay. I thought it was very good. The thing that I hear most is about people waking up, not eating, after dinner, and then waking up with high blood sugar. That's the thing I hear most common. So I thought your description of that was very helpful.
Yes. So overnight, honestly, I see this quite a lot. It's called the dawn phenomenon, which is just a fancy term for your body needs that sugar to keep your body going overnight. And so now you wake up and it's high and you're like, but I didn't eat all night. I'm not sleep eating. I'm not sleepwalking and eating 2 pizzas. Why is it high? And it's really just because your liver, he's trying to be a nice guy. He's trying to help you out and give you the sugar that you need. But when you're insulin resistant, your body still can't use all of it.
So is there a medication that you see the most being prescribed?
Absolutely. Metformin is the most prescribed medication for diabetes. I do see the glipizide, glimepiride. That's actually decreasing in popularity. It's not prescribed as much. There's a little bit of research that's going on to see if it actually affects the pancreas long term. There are some concerns that your pancreas won't be able to continue to make that much insulin. But so far, it's been around since 1956. So far we're still doing some research into it, but that's why it's kind of lost a little bit of ground.
Got it. So can you touch on changes in diet needed for someone who has been recently diagnosed with diabetes?
Absolutely. So first of all, what we always encourage, again, going back to the carbohydrates, you want to reduce, not eliminate your carbohydrates. So carbohydrates are foods that are starchy. If you think of your pasta, bread, potatoes, tortillas, beans, rice, all of those things are really high in carbs and they turn into sugar. So all carbs turn into sugar. What we want to do is look at the carbs that take longer to turn into sugar, because that's actually going to decrease that spike. When you give kids sugar and they all of a sudden have all this energy and then they crash, that's what actually happens to our blood sugar when we eat simple carbohydrates like white pasta or white bread or white rice. Okay, but if we can add in those whole grains, those brown breads, all of the higher fiber foods, then we actually see this nice little curve that raises your blood sugar some, but then your body has time to bring it back down. So that's why I also say we want to look for those 45 to 60 grams of carbs per meal. And that's when you look at a nutrition label. So you're looking at the total grams of carbohydrates, and whatever's in your meal, you want that to add up to 45. If you're still hungry, and this is what I really like to focus on, all the colorful vegetables you can have. If it has color, eat away. You know, if it's eggplant or carrots, tomatoes, cucumbers, avocados, all those foods are so good for you. They're so healthy. They have so much fiber, and they also don't raise your blood sugar. So those are really good areas to focus on in decreasing those carbohydrates.
So I like how you brought up vegetables. As far as medication goes, is there anything, any sort of vegetable or any sort of fruit that you might want to stay away from around the time that you're taking your medication?
Actually, that's a really good point. So, grapefruit is notorious for affecting medications. I do know that there's one cholesterol medication and blood pressure medication that are affected by grapefruit. So, stay away from those within an hour or two of taking it. The other thing you want to watch out for is taking any kind of medication, but especially diabetes medications, when you're eating things that are extremely high in fiber. So cactus juice is very popular in some cultures. It does a great job of regulating blood sugar, but if you take your medication at the same time, it actually can half the effectiveness of that medication. So it's better to space it out by an hour or two between those things. So anything high fiber, I know sunchokes are a little bit popular right now. I think yucca is another one. Those really, really high fiber foods, you want to try and space your diabetes medications out. Now, insulin, not really going to matter that much, but the pills that you take really will matter.
Okay, do we have any more questions?
I do know that it was a lot of information, and it was very detailed as far as those different names of medications and types. But I do think it's something that helps when you go to your doctor, that you can talk to them. And even if you don't remember what I said, you recognize that name. You know, you don't feel like you're going in there blind, and you don't feel so vulnerable when you go to the doctor, because you have this little bank of knowledge of things that they might say.
I love it. So I do also want to remind everyone, if Rachel has said something that you couldn't quite get the spelling down right, and you want to bring it up to your doctor, this, as I'd mentioned, is being recorded and it will be placed on YouTube. So I will be sending a link out with how to watch it again. And the most beautiful part is that you can pause it and write down or take pictures of those names, so that whenever you go see your doctor next time, you can ask questions.
Excellent.
All right. Well, Rachel, that was very informative. Thank you so much. I know I definitely learned a lot.
Well, it was nice to talk to you all, and I wish you good luck with your diabetes management. You know, it's a lifetime management, but it is something that gets easier with time and becomes a really good lifestyle change eventually.
Absolutely. Absolutely. Okay, everyone. Well, have a good evening.